Well, great. Well, it's been a great discussion so far this morning, and I'll focus on a few key lessons that have been learned by these landmark studies. And they're highly relevant, I think, for this audience as individuals who are directly trying to help and advocate for patients with MPNs for a variety of reasons. You know, we know as you're trying to advocate, whether that be to government officials, whether that be to payers, whether that be to anyone that provides support to individuals that suffer from these diseases, or for you yourselves. There's information in here that hopefully is beneficial. Some of this is data dense, and I am mindful of the range of languages and things of that nature that we all speak. So certainly all of these are available to you to review, as well as the actual papers that have been written from these studies. So the origin really of the landmark studies, I think, as we've heard from both of the wonderful speakers this morning, is really trying to focus on the burden of having an MPN. And clearly there are many deep conversations that can be had around that piece. As we started this journey, I think many years ago, largely brought forth first from advocates like yourselves, people like Bob Rosen from the MPN Research Foundation, Joyce Niblack, and others. You know, they challenged us as a medical community to say, you know, there's a lot more to having an MPN than just having risk of blood clots and bleeding. Because primarily that was the only thing most hematologists were really taught. The only thing you have to fear about an MPN is a blood clot or bleeding. And that, I think, led to a disconnect in a variety of things in terms of goals and in terms of treatment. We now know that it's a varied mix of burdens individual can face. It clearly can include the risk of vascular events, and we clearly cannot ignore that, or that clearly can be very harmful in and of itself. We know that the potential of the blood counts eventually becoming low is a major factor. We know the issue of progression is very relevant. It's a great concern to many of you, to many of us, yet it's not really been a large part of the decision-making for treatment. There is the issue of the spleen. Sometimes this can become very problematic. There are the issue of symptoms that we'll discuss in a moment. And of course, none of this happens in isolation. I think increasingly we realize as a chronic disease, the health of the rest of the individual is crucially important. Both kind of the mental health, as you saw from these last presentations, as well as clearly the rest of the illnesses present. You know, you could tell me I have two patients with PV, but if one is a 75-year-old man that has heart disease and the other is a 25-year-old woman who has no symptoms and no other medical problems, they face a very different set of risks. Now, our group was engaged, again, in large part with partnership with MPN groups to trying to define this issue of the subjective. Symptoms are by their nature subjective. You know, how itchy am I? Only I can really answer that. And only I can really answer, is that better or worse over time in relationship to a treatment or things of that nature. So with that, we've developed a series of different tools that now are available in many of the languages represented here around the room. And there's data that's been gathered in several thousand patients with MPNs. And I could share with you, we've learned a lot of things. And we've learned that patients around the world are surprisingly similar in terms of the ranking of where their symptoms fall by disease. Now, the severity does tend to be influenced by culture, but not the ranking of the symptoms. This is an example of one of the most validated of the tools. These are just 10 questions that act as a good cross-section of symptoms for MPNs, both in English and Arabic, obviously read in different directions, where an individual can track the symptoms that they have. Now, these have become largely a standard place in MPN clinical trials, and in many ways have become a model across other blood cancers and cancer as a whole of having a deep partnership between investigators and patients and having patient-reported outcomes be included as part of how we assess the impact of a therapy. Now, with this, we had seen that there are many symptoms, both in terms of how they are prevalent and how severe they are. Now, what I think is surprising to most physicians is how many symptoms can be present also in PV and in ET. In MF, I think people now understand this. When we started this journey, the first paper I had with 1,800 patients with MPNs was summarily rejected because a reviewer said that he had 2 MPN patients. He didn't think either of them were symptomatic, so that he thought these other 1,800 patients were exaggerating their symptoms. So that's truly where we began, with a very dismissive attitude from the medical community. And over time, that has evolved. Now, what we have learned over time is that symptoms are not solely linked to the label of the disease that an individual has. This is data shown in a colorful form. Each line from top to bottom represents one individual patient. And then each color goes from blue absent to red highly present in almost 2,000 patients on this single slide. And what one is able to see by quartiles, a total symptom score of less than 8, 8 to 17, 18 to 31, or over 32, these are 25% of each of the groups. What we learn from this is that there's great intermingling between these quartiles of ET, PV, and MF, and this will be relevant as we show you some of the landmark data as well. You can see as well some symptoms that really are almost universal across the board. You see the red lines that really come across. Fatigue, issues with insomnia, issues of intimacy. Now, intimacy is almost never discussed in these settings, but in many ways is really a way to distill down many aspects of quality of life. In general, if someone's quality of life is poor, intimacy is something that goes out the window first. And likewise, if people really are feeling more like themselves, then it resumes its natural place in their relationships. So it's actually quite an important litmus test, in my mind, as to how someone is actually doing. Now, people had raised the concern, well, patients are saying that they're fatigued, what have you. You know, I'm fatigued, I'm taking my children to ballet, I'm working. You know, I'm not convinced that MPN patients are more symptomatic than the general population. Again, some of these reviews, I really should have saved them because they are so filled with hubris that it's hard to describe. But regardless, our colleagues from Ireland were interested in this and did a study with a comparator group in the general population, and were able to show that in ET and in PV that there was a clear difference in individual symptoms between ET and PV versus the general population. Now, what about the landmark studies specifically? So the purpose of the landmark studies, of which there are 2, were to try to quantify a few key items. And this was really a very team-based effort. It was supported by Insight, but it was done in an independent way with stakeholders from the patient community, different perspectives, investigators, etc. And they put together a range of questions, of which I was involved with helping to lead this group, to try to get at several different parts: burden of disease, impact on employment, communication with physicians, how symptomatic they were, kind of a cross-section of a range of different topics. In addition, there was a physician component where physicians were also asked similar questions, goals, etc. This is one of the manuscripts which came from this, and this was that there's the significant impact on health and productivity. Now, some of this, in the interest of time, I'll leave for you to just have data that you'll be able to review from the slides. The baseline demographics of individuals, this was a representative group. I won't dwell on this part, but it was a representative group of MF, PV, and ET with several hundred people in each group. The disease features, again, were a range of risks, and this was intentional. We wanted a cross-section of the disease, because many of the things that you'll read in the context of a clinical trial are relevant, but are skewed toward people who are more ill. So obviously, if you went onto a clinical trial, let's say the data from Comfort-1 in ruxolitinib, that's very relevant, but of course that was people who were sick enough to have to go on the clinical trial. So that's a certain select group. We looked at the comorbidities, and to large part, it just represented a cross-section of the population. Some people have diabetes, some people have kidney disease, some people have other issues. Some were clearly related to having the blood disease themselves, but there was not a dramatic dissimilarity to the mixture of diseases that we might expect for that population. Now, in terms of symptoms, we found that the symptom burden actually matched very well the symptom burden we had gathered from our other online studies that we had performed, which helped to really validate things on many levels. One, it was pretty consistent, using a completely different group of people that had answered one set of activities versus the other. Two, many of these symptoms, which you'll see fatigue is by far the most prevalent, is the most severe in MF, but clearly is still very relevant in many of these cases with both PV and ET. As we had seen in other studies, itching is by far the most linked with polycythemia vera, although it can be present in MF and ET. So again, in many ways, demonstrating the clear similarity to other information that had been gathered. It's also clear that as a group, MF is more symptomatic than PV, which is more symptomatic than ET. Now, but any individual in any of those three groups might be either more or less symptomatic. Now, in terms of the symptom burden itself, you see again in blue the myelofibrosis patients in general being the most symptomatic. However, in many cases, that only being slightly more symptomatic than the other groups. And I'd say if there's an unmet opportunity that we largely have to dispel amongst many individuals, is that PV and ET patients don't have problems from their disease. And one of the goals was to try to understand the impact on the daily living and work productivity and quality of life. So 81% of people responded with MF said that their symptoms directly reduce their quality of life. So that is obviously a subjective question. Only you can answer, okay, you have symptoms from your disease. Does it really impact your quality of life? And the majority of them said that that was in fact the case. One of the things we saw that I had been highly suspicious of was that the prognostic risk for the disease, that DIPSS, IPSS, or these other scores that are created to estimate the likelihood of a disease being life-threatening, is not a substitute for saying how problematic the disease is. Individuals may not necessarily pass away from their disease soon, which is good, but that does not necessarily mean that they don't suffer from their disease with difficult symptoms. Individuals having to cancel planned activities, individuals having to call in sick or leave work early. And indeed, I'll show you some data later on the impact it has really on employment on a range of levels. Now with PV, the issues were still very similar. Again, in terms of prognostic risk, it didn't really matter where one stood in terms of the risk of blood clots and bleeding versus where they stood in terms of their risk of symptoms. They are complementary issues that need to be addressed. And why that's relevant is I see a lot of patients with PV who are sometimes undertreated for their PV who are highly symptomatic, but because they've not had a blood clot or their age is not over the age of 60, they do not receive adequate therapy. Similar sort of information in ET. And again, with both the PV and ET, we saw that of those quartiles, there are many individuals who still can be in that most symptomatic quartile. Having the label of ET does not mean you do not have symptoms from your disease. There's an impact on the activities of daily living. Now, as we talk about activities of daily living, in a disease like the MPNs, it is different than sometimes how this term is used, let's say with an advanced cancer. People will use these same sort of methodologies for someone with advanced pancreatic cancer, etc. Here we're not speaking of not being able to do things like brushing your teeth. What we're really talking about in MPNs is really curbing one's lifestyle in ways to really modify for the limitations of the disease. So although it does not have the severity one might see in comparison with the group, let's say, with multiple sclerosis or Alzheimer's or really severe debilitation, it still is highly problematic. It just has a different impact. And in terms of work productivity, we saw, again, in MF, right, 60% of the people had an impact on work hours or leaving a job early or early retirement, which I think is a big factor as well. There are some individuals that have already retired already, but clearly there are many features. Again, the 60-year-old that has chosen to retire probably earlier than they would have chosen otherwise because of the impact of their disease. There's a whole range of impact on the hours of work, the duration of work, etc. Now, what about treatment goals? This was another key point that we wanted to look at. What were the patient's goals and what were the physician's goals? As we looked at the treatments, the distribution of treatments was somewhat what we had expected from the general population. So what we found was that this was the first large survey really to look at the experience in the U.S. of MPN patients, that they had a broad symptom burden with reduction in quality of life, functional activities, and work productivity, and that it does really have an impact for them. Now, in parallel, there was a second study, or a second analysis that we did on that same data regarding differences with the expectations of the physicians. So again, similar in terms of demographics, we looked at the discussion between patients and physicians regarding communication of the MPNs. A couple of things. One, patients who did not recognize some of their symptoms as being MPN related, and of which there were many of them. Indeed, I have some patients who tell me that they don't have symptoms, and then after they start on the therapy, they're like, wow, I feel a heck of a lot better. And of course, these symptoms just did not come on overnight. They came on over time, they adjusted, they had a positive attitude, what have you. Sometimes you don't know how much better you can feel until you feel better. As we look at the likelihood of having symptoms at the time of diagnosis, this tells a little bit of the challenge that we have. This was the percentage of patients who reported MPN-related symptoms at diagnosis, 81 to 89%. These were the physician-reported percentages of patients with no MPN-related symptoms at diagnosis. So fairly consistent in MF. So this means that they think about 90% had symptoms. But in PV and ET, they only thought about half of their patients or less had symptoms versus the majority which did. Now, one of the interesting observations was a discrepancy between the treatment goals. For patients, the biggest discrepancy is that the desire to slow progression of the disease was one of their primary goals. And for physicians, it was to control the blood counts. Now this, I think, at its core, gets to really the core issue. Physicians have been taught, make no mistake, that the main priority in MPNs is to avoid a blood clot at all costs. And all of the decisions and guidelines that have been developed around aspirin and phlebotomy and hydrea, on and on, was solely based on that metric. Clearly, from your end, avoiding progression of the disease is very important. And this brings us out to a great degree. And I think one of the limiters are physicians have struggled with, I don't necessarily know how to avoid progression for you, so they don't even really focus upon it. So I share this with audiences of our MPN investigators to really highlight that importance. The same was very true in polycythemia vera, as was true in ET. Now, physician satisfaction with physician management overall showed that there clearly were opportunities, and many of these related to the ability to converse, discuss, and come up with a shared treatment plan. So again, a discrepancy here that we hope with some of these efforts can be utilized to try to advance both communication and research. Finally, a parallel study had been conducted subsequently. I played a consultative role in this. This was in additional countries, including not the full spectrum that we have here, but it did include the UK, Germany, Italy, Japan, Canada, and Australia. Similar methodology, different questions, although very similar in style and structure. With this, again, almost 700 patients. And again, similar observations with significant symptomatology, again with high prevalence of fatigue, particularly being common. We saw, in terms of severe symptoms, how many individuals had symptoms reported as a greater than a 6 out of 10. We saw, again, these are people in which you think it'd be highly problematic. These are the absolute numbers, but you see how common some of these are. So 390 out of the 700 really had that as highly problematic. You saw issues of depression or sad mood, inadvertent weight loss, headaches. Some of them rare. You see blood clots occurred, but only in 26. So again, some rare, but some much more common. So when we also asked what would be the primary goal of people in terms of their treatments, clearly improvement in fatigue was at the top of that list. Impact on quality of life very much mirrored the observations in the US-based study. The impact on work demonstrated a range of impact on work across these different 6 countries, ranging from, again, early retirement to reduced hours, etc. So again, very similar conclusions. Significant burdens, a range of impact on activities, and impact in terms of for these individuals as a whole. So I'll leave it both for questions, as well as there were a couple discussion points raised in terms of how these information may be of use for you as you have discussions, particularly within your own country or some of the audiences that you have to discuss around MPNs and what burden individuals face, as well as how you help to advocate for them, whether that be around a medication or an accommodation or even a flexibility regarding things like work hours. Thank you.